everyone, thank you for completing the poll. I'm Olivia Anastasio and I'm the Digital Marketing Officer for the Sickle Cell Society's blood donation project, Give Blood, Spread Love. Today we'll be joined by Debbie Omodele, our Give Blood, Spread Love volunteer and sickle cell and thalassemia specialist nurse, who will be speaking about everything from genotypes, origins and history, inheritance patterns, common triggers and treatments. We will also be joined by our lovely volunteer, Bola, who will be sharing her story and personal experience with sickle cell. Just before we begin, I just want to highlight that approximately 15,000 people in the UK have sickle cell, but only 1.5% of blood donors are of Black heritage. Our project aims to raise awareness and sign up new donors to support people living with sickle cell that require frequent blood transfusions. So if you can donate blood, please sign up today. I'll put the link in the chat shortly. It's bit.ly/SES Give Blood. And if you can't donate because you have sickle cell or for any other medical reason, then please help us in raising awareness, share our link, follow us at Give Blood Spread Love on Instagram and help us save lives. So, sorry, I'm just going to let a few more people in before I carry on because it's popping up. Perfect. So we will also have a little bit of time at the end of today's session for a Q&A where you'll have the opportunity to ask Debbie some questions around sickle cell and the benefits of blood donation. To note, we will not be giving any medical advice or answering any specific questions around your condition. The session will be recorded, so please turn off your camera and if you would not like to participate in this, and we will come to a close at 7:30. Thank you so much, and I will now hand things over to Debbie, who will be leading today's session. Hi, Debbie.
Hi, thank you so much, Olivia. Thank you all for joining this evening. I hope you've had a good Monday. So, as Olivia said, my name is Debbie, and I am a children's sickle cell and thalassemia nurse specialist. I've been a children's nurse for over 16 years, so I have a wealth of experience of general pediatrics and also in my specialist field, which is sickle cell and thalassemia. I've just recently joined the Just Giving squad to encourage people to come forward and donate. So today's session, we're just going to be talking about sickle cell disease and going back to basics, just like Olivia introduced. So we're going to start. So all questions, please either put it in the chat or you can ask them during the question and answer session. Okay. And I do apologize. My desktop doesn't have a camera, so I can't turn on my camera because there's no camera on this desktop. So I do apologize, but it doesn't affect me sharing the slides. Okay, so today we're going to be talking about what sickle cell disease is, the origins and the history and who it affects, genotypes. We're going to be looking at a couple of inheritance patterns, so how sickle cell disease is inherited, some of the common triggers, some complications of sickle cell disease. We're going to be looking at some treatments, and just before the Q&A session, we're going to have Bola talking about sharing her story, and then would have Q&A. So what is sickle cell disease? So sickle cell disease can be described as a group of inherited disorder that is caused by an abnormal hemoglobin. So a normal hemoglobin, normal blood cells are round in shape and they have the ability to move through blood vessels very easily, so through your circulations with no problems at all, including the very small blood vessels. Each red blood cell contains a protein called hemoglobin, and that lives inside the red blood cell. So this hemoglobin swims nicely inside the red blood cell, and as it's going through our circulation, it gives up the oxygen to the various tissues. So a normal hemoglobin is known as hemoglobin A, so that would be what that individual has inherited. However, in the sickled cell, it is caused by an abnormal hemoglobin that has been inherited from parents. So this abnormal hemoglobin, what happens is once the oxygen has been released into the tissues around the body, it starts to stick together, and then it starts to form what we describe as long rod-like structures, and then it distorts the normal shape of a normal red blood cell. So instead of it maintaining its round shape like the normal hemoglobin, like the normal red blood cell, it distorts the shape of the red blood cell, giving it its sickle shape or a C shape. So this hemoglobin is known as hemoglobin S. So it changes from the normal red blood cell. Once the oxygen has been given to the various tissues, it then changes to the sickled cell. Okay, so sickle cell disease has been around for many years. It was first reported by a doctor called Dr. Herrick in 1910. And there was a lot of research going on around this time where they found that people who came from the sub-Saharan parts of Africa, the North and South America, the Southeast Asia, the Middle East, the Caribbean, there was an increased number of people with the sickle cell gene and also sickle cell disease. So during this research, what they discovered is that areas where malaria was an endemic, there was also, so that means where it was widespread in this particular group of people, they found at least about 40% of people within these areas carried the sickle cell gene. And what that means is that being a carrier, you have about 30 to 40% of your red blood cells that can sickle. So people who came from these parts of the world had some kind of immunity. So they had partial immunity to malaria. So we know malaria is a deadly disease, and the one that is most severe is the Plasmodium falciparum. And that's the one that was found in these areas. So people who didn't have the abnormal hemoglobins were dying from the complications of malaria. Those who actually have the disease, so those who had sickle cell disease, their condition was triggered. So the complications were triggered by the malaria parasite, by this infection. So they were not getting better. So some of them died from the complications of malaria. But those who actually had an abnormal hemoglobin, like the sickle hemoglobin, were surviving. So what they found was that because of gene evolution, so the body almost like tried to protect itself, what they found was that people who, what happens is that those who are carriers of the sickle hemoglobin, we have an organ in the body called the spleen. So the spleen is on the left side, and one of the jobs of the spleen is to filter out bacteria. It also takes away red blood cells that are not working. So because malaria likes to multiply inside red blood cells, it's going to affect the function of a red blood cell. So what the spleen will now do is to take away the damaged red blood cell together with the parasite inside the red blood cell and takes it out of circulation. And because it's taking this out of circulation, it reduces the parasite from multiplying in other red blood cells. And this increased the gene pool of those who are carriers of this sickle cell hemoglobin. So that means it's more likely for somebody with a carrier to meet a carrier in these areas, and they were more likely to there was a risk of them having a child with sickle cell disease. But we still advise that those who are carriers should still take their antimalarials, because we don't know if what percentage the partial immunity is. So is it 10%? Is it 50%? Is it 90%? We don't know. So we still advise, if you are in this country and you're traveling to known malarial areas, still take your antimalarials. So against popular belief, a lot of people think sickle cell disease affects Black and brown people. Rather, it's a global disease, and it can be found across all ethnic groups. And I think the more we start to shift our mindset away from this belief that it's a black and brown disease, which I think has contributed to some of the health-related stigmas that has been attached to sickle cell disease. I think the closer we start to bridge that gap of health inequality, improve education, improve the care provisions for those who are affected by these conditions. So as you can see here, for example, if this young lady was to have a baby with somebody of a Caucasian background, for example, their child would move far away from the typical appearance that we are expecting a sickle cell individual to look like. So what I always say, it's not in the color of your skin, it's all in the genes. It depends on where your ancestors are from. It depends on the genes that you've inherited that will determine what genes you carry. I think I've explained this. So sickle cell carriers, they tend not to have any complications because the majority of their hemoglobin is the normal hemoglobin A. But of course, under stressful conditions, so for example, if they were going for a surgery that required general anesthetic, it's important for the anesthetic team and the surgical team to be aware that they are carriers, because under stressful conditions, this 30 to 40% can sickle, and they can get that complications of their red blood cell breaking down. And of course, that could cause problems post-operatively. So we're going to be looking at genotypes. So a normal genotype is when an individual has inherited normal hemoglobin. So they would be known to have a genotype of hemoglobin AA. That means they've inherited normal hemoglobins that hasn't got sickle or thalassemia. If you're a carrier, you've inherited one normal red blood cell from your parents, and then you've inherited a sickle. So this is what your kind of red blood cells would look like. And for those who have inherited hemoglobin S, so they would have inherited 2 sickle hemoglobins. And if they've inherited hemoglobin C, so when hemoglobin C is looked at under the microscope, it looks like crystals, so it forms crystals in the red blood cells. So we tend to advise those who have hemoglobin C, especially, to have annual checks of their eyes, so ophthalmology checks, because sometimes this red blood cells could block the retina, which is the blood vessels that feed the eyes. So it's very important for them to be aware of these checks that they need to have. So these letters, as I said, they're known as your genotype, and the others include A beta. So this is where they've inherited a beta thalassemia gene from a parent, AC, AD, AE, and so on. So what they do is that they name them after letters. Once the letters are finished, they name them after places. But these are the ones that are the most common that we find. I've just popped this picture here because a lot of people ask me, what is the difference between blood type and what is the difference between a genotype? And this picture from the Sickle Cell 101 explains it brilliantly. So your blood type is what you've inherited, is the antigens that you've inherited from your parents. So basically, your antigens kick up an immune response when there's a foreign body that has been introduced in the body. So like infection, or if it's the wrong, for example, the blood type that has been given to an individual, it kicks up a defense and says, hey, wait a minute, what's this foreign body that is going on in circulation? And then what happens is that those antigens then takes that out of circulation. Your genotype is what you've inherited from your parents. So your genotype can't be donated if you were to be a donor, but your blood type can be. So the blood type is what you can donate and what you receive, but your genotype is what you've inherited from your parents. So these are some of the common sickle cell disease that you may have heard of or come across. So the most common type of sickle cell disease are HBSS, which is also known as sickle cell anemia, HBSC, S beta 0, and others that are clinically significant but not as common are S Lapor, SO Arab, SD Punjab, and SC. So we tend to say that, for example, if they were to have a painful crisis, which I'll be explaining in future slides, they were to have a painful crisis and they were to come into accident and emergency, they would still need the same treatment because they will be having a painful episode. So regardless of what their genotype is, the care that they require in A&E for a painful crisis would remain the same. The only time that this genotype is important is to do with certain scans that a certain group need to have every year. So this is just going through quick inheritance patterns. So for example, if both parents are carriers of the sickle cell hemoglobin, there is a 1 in 4 chance with every pregnancy that the mother carries that she could give her A, father gives his A, the child will be HBAA. A from mom, S from dad, the child will be a carrier. A from dad, S from mom, the child again will be a carrier. However, if the child inherits S from mom and S from dad, that child would have sickle cell anemia. And the previous school of thought was that is the 1, 2, 3, the fourth child. And that is incorrect, because it's with every pregnancy that the mother carries. We don't know what genes the baby's going to pick up, that there's a chance to have a child with, there's a risk of having a child with sickle cell disease. If the mother, for example, in this scenario has sickle cell disease, that increases the risk to 50%, that the mother could give her S, father gives us A, the child will be a carrier, S from mom, S from dad, the child will have sickle cell anemia, A from the father, S from the mother, again a carrier, S from mom, S from dad, again that child will have sickle cell disease. And this is just a visual picture. This young girl here, she's called Hercycle Journey. She shares her journey and advocates for sickle cell patients on her Instagram. And this is just an example of a family where, you know, one of the children out of 3 have got sickle cell disease because of both parents are carriers. So how is sickle cell disease diagnosed? So in this country, we have a universal screening program that I believe started in, I think it's 2004, where every baby born in this country are offered the blood spot screening test. So the midwife goes home, takes some blood from the baby's heel, pops it on the card, and then sends it off. And whatever results that's of whatever the outcome of those results are, it will be sent to the different hemoglobinopathy centers, so the different sickle cell centers. So usually at day 5, this test is offered by the newborn blood spots. The other ways that it can be diagnosed is through prenatal diagnosis. And this is when the baby is in the belly. So through amniocentesis, where a fine needle is inserted into the mother's belly, and some of the amniotic fluid is obtained, and that is sent off for DNA testing, because the amniotic fluid has an abundance of genes that the baby is carrying. So we can diagnose by that. We can diagnose sickle cell disease by that route. And through chorionic villi sampling, so this is when the mother is at 8 to 12 weeks gestation. So again, it's just another route to obtain the amniotic fluid, so it can be diagnosed by that. And this is all when the mother is pregnant, or for whatever reason that the patient or that the individual missed the newborn screening program, perhaps they were not born in this country, we can diagnose it through venipuncture. So that's where you go for a blood test. Blood is drawn from the vein, and it's very important that they write on the form that is a hemoglobinopathy screen, because if you don't write that, it would not check the genes, it's just check your FBC, so that's just your normal blood values, but it's important for them to write HBO screening, and that can be diagnosed that way. So what are some of the triggers of sickle cell disease? So some of the common triggers are a sudden change of temperature. So when it goes from hot to cold, raining, just like the weather we're having right now in UK, that could trigger a crisis. Excessive exercise. So when that patient or that individual has overexerted themselves, either physically or even mentally, can trigger a crisis. Infections, dehydration, because again, what happens with the sickled cells is that when the oxygen has been released into the various tissues and they start to clump together, so they get very sticky, and then they can clump together and block the entry and exit points of blood vessels. So dehydration would heighten that and can cause a crisis. Stress, sleep apnea. So this is where there's an interruption of oxygen gas exchange in the lungs, basically. So where that child or that individual is holding their breath for a few seconds. So that could trigger a crisis, because again, no oxygen is being delivered to the various tissues. And increased altitude. So for example, if an individual with sickle cell disease wanted to be super adventurous, they wanted to climb the mountain, they need to be aware that at really high altitudes, there's a lower concentrate, there's lower pressure of oxygen, and that could trigger a crisis. And of course, if they wanted to go deep diving, deep into the sea and discover all the, aquatic animals that we haven't discovered yet, they need to be aware that they need to have a backup of oxygen, because again, there's a low pressure, there's a low oxygen pressure deep down in the sea. or in the ocean. Lifestyle choices. So, for example, if we advise that they should increase hydration, ensure that they have enough rest. They should understand what their triggers are, what their boundaries are, to ensure that they don't trigger a sickle cell crisis. So, for example, I lead on the transition of patients from the children's services to the adults, and what I tell the teenagers is to be mindful of when they go into university, and they're going for Freshers Week, and maybe they want to wear a crop top and a short skirt, and just to be aware that exposure to these triggers can trigger a crisis, which means that they would possibly be, MIA, nursing their pain crisis for a while. So it's very important for them to be aware that, okay, yes, I want to go out with my friends, but I need to wrap up warm. I need to make sure that I'm drinking enough water so I don't miss out on all those social activities. So for sickle cell disease, there's a lot of complications that can happen. So anywhere anywhere blood flows, there could be a crisis, but the most common complications are a painful vaso-occlusive crisis, which means where there's a blockage of the blood vessels. So blood can't flow in or flow out. So blood cannot flow through as well as it should. Anemia, so where there's a low hemoglobin. Acute chest sequestration. So what that means is just acute chest crisis where the sickled cells has blocked the lining of the lungs, which means that that individual will not be able to breathe in deeply. And of course, that would inhibit efficient gas exchange. So oxygen will not be able to go in. And then, of course, that causes problems because it's to cause respiratory issues. Infections, because as I explained to you, the spleen is on the left side, and over time, what happens is that an individual with sickle cell disease could lose the function of their spleen. And this is because anywhere the blood flows, there could be a blockage within those blood vessels, and they're blood vessels that feed the spleen. So over time, there could be many blockages happening inside the spleen. So over time, that tissues around that area would start to get damaged, and they would start to lose that function because the spleen would start to shrink. So of course, if the spleen shrinks and loses its function, it's lost that function of being able to filter out certain bacteria. So that means that that individual will be more vulnerable to certain infections, which is why we recommend penicillin prophylactically every day, morning and evening, to reduce the risks of a certain bacteria called pneumococcal bacteria, which lives dormant in our nose and in our throat. So when our immune system is a bit weakened, that can become active. And if that individual does not have that spleen to take that pneumococcal bacteria out of circulation, that child will be vulnerable to, for example, pneumococcal sepsis, which is blood poisoning. And of course, that is a severe complication. Splenic sequestration. So again, that's a spleen crisis where all the red blood cells is pooled inside the spleen. So it can't go in, it can't go out. And that is because of the blockages that those sickled cells have. So those sickle cells have blocked the blood vessels within the spleen. And of course, that's a medical emergency. So others include strokes can happen. So again, anywhere the blood flows, there could be blockages, and this could also happen in the veins in the brain. Aplastic crisis, which is where all the red blood cells have been reduced drastically, and this is usually due to a certain virus called parvovirus, and we usually test for that by a blood test, and that's how we know. But the child or the individual will be quite pale when we do their red blood, their full blood count. Their hemoglobin could be as low as in the 30s. So again, that's the medical emergency. Priapism. So priapism is a painful, unwanted erection that lasts for a prolonged period of time. So some males experience this on and off, so which is called stuttering priapism, where they experience it for 30 minutes and then it goes again. But when it's a prolonged period of time for over 3 hours, we advise them to come into A&E for treatment. And also gallstones. So gallstones can happen as a byproduct of all the red blood cells breaking down quite rapidly. That could collect in one of our organs called the biliary duct, and it can form really small stones, or they can be as large as pebbles as well, and that can cause stomach problems. Psychological. So this is the psychology, the psychological effect of sickle cell disease is often overlooked. I think we tend to focus a lot on the physical side, but the mental strain, the emotional burden of, having this condition where they have to take medication every day, they have to attend appointments, they miss out on social events. So this is an area that, anybody who comes within our service, we advise that we let them know that we thankfully have a psychologist attached to our service. And I know that's not the same for a lot of services. So the psychologist would, support them with managing their emotions, managing how they see that, how they see them, how they understand their conditions, how their conditions make them feel, and just to help them process those emotions so that they develop good coping mechanisms, so that they don't fall into, for example, depression, or they have an outlet basically to talk about how they feel and how those feelings affect them on a day-to-day basis. Oh yes, an exhaustive list. So a sickle cell crisis, as I explained, so this is just a visual. So as you can see here, that those sickled cells has blocked the blood vessels. So the normal red blood cells will be trying to squeeze past this blocked area, but it can't because it's been blocked by these sickled cells. So this area is being starved of oxygen. So what that means is that this individual would be experiencing excruciating pain, because when oxygen is not being delivered to the tissues, those tissues start to get damaged, and of course over a prolonged period of time that can cause long-term damage. So the treatment usually is pain relief, fluids to try and unblock this blockage and just to encourage blood flow. And this is just a GIF again, just to see what is happening here. As you can see here, there's a bit of a traffic jam going on here, so the red blood cells can't go through. So this individual will be in a lot of pain. And further down the line, you can see that the red blood cells are slowing down as well. So again, there must be a blockage happening further down the line. This is very painful, and this requires pain relief. And of course, when they come into A&E, this should be treated as a medical emergency to avoid pain escalation. Okay, so dactylitis, also known as hand and foot syndrome. So this is the first symptom in infants, and it's typically when they're under 1 year old, but it can be up to 2 to 5 years old. So this is one of the first signs of a vaso-occlusive crisis, and it occurs in about 30% of patients, and like I said, within the first year of life. So this is usually, the treatment is usually managed with simple analgesia, and then it kind of subside, and of course a lot of fluid and just rest. I advise parents that, if your child ever has dactylitis, just leave it alone. Don't try and, because sometimes blisters can come up, and a parent has told me that they've tried to pop it. Please don't do that. Just leave it alone, because we know that is the sickled cells that has blocked the small blood vessels within the fingers and the toes. So what they need is that hydration and also that pain relief to reduce the amount of pain that this young child would have. But of course, if they can't manage this pain at home, we advise them to bring them to A&E, where we can give them strong pain medicine, for example, like morphine. And of course, if they need IV fluids, if they're not tolerating oral fluids, we pop them on intravenous fluids. If nothing is done about this dactylitis, where it keeps happening and maybe it gets better, or there's a prolonged period of time where this has happened and maybe nothing is done about it, it can affect the digits of the hand. So this is called short digit syndrome. So as this baby is growing, because the tissues have been damaged by the red blood cells, and of course that blockage was not unblocked on time, the tissues around those fingers and toes would have been damaged. And of course, as the child grows, the digits of the fingers would not grow. The one that is affected would not grow along with them. And of course, that causes a lot of, problems in terms of self-image and so on. So please, I always advise, if your child has this, try and manage this complication at home. But if you can't and you see that the swelling is not going down, reach out to your clinical nurse specialist team or just bring your child to A&E. So other complications include the brain, as I mentioned. So anywhere the blood flows, there could be, a blockage. So, for example, stroke can happen because if your brain is starved of oxygen, then a stroke can occur. Usually in the joints, so any part of the body. So this is the most common areas that individuals with sickle cell disease complain of pain in the lungs. So as I explained with the acute chest crisis, and this is where the sickle cells has pulled and blocked the lining of the lungs, so that individual will not be able to take deep breaths in, and effective gas exchange would be inhibited. So in the spleen, as I explained, it's in the left side of the body. So again, if all the red blood cells pulls in there, it becomes enlarged, and how it grows from the last rib on the left side, and it grows downwards into the towards the belly button. So we always advise parents to feel for the spleen every day or every other day, so you would be aware of you would know when the spleen is getting bigger, or if there's a change, then you can alert your clinical nurse specialist. And of course, if the child is experiencing pain, or if they look pale, or they're just generally unwell and lethargic, so if they're really tired, then you bring them to A&E. And of course, it can affect the eyes. So because the red blood cells are breaking down very quickly, the byproduct of red blood cells is called bilirubin. So bilirubin shows up in the eyes as that yellowish color. So this can affect those with any of the genotypes that I explained, but this is most common in those with hemoglobin SS. So what we tend to advise to try and clear the jaundice is to drink lots of water. And also, if this continues, we can obtain a blood test. We look at the bilirubin levels to see if it's at a really high level, and then we carry out further investigations to see if there's anything else going on in the body. So some of the current management and look into the future. So some of the supportive therapies that we have are hydroxy. So I don't know if any one of you have heard of hydroxy. So hydroxy is a medication that is taken orally. And what it does is that it switches on the production of hemoglobin F. So hemoglobin F is the fetal hemoglobin. So fetal hemoglobin is the hemoglobin that you find in abundance in fetal life. And this is because fetal hemoglobin does not have the ability to sickle. And that fetal hemoglobin is very important in while the baby's in the belly, because by the time in the maternal blood circulation, by the time it gets to the placenta, it's at a really low concentration in terms of the oxygen. So the oxygen is at a really low concentration. So the hemoglobin F has a high affinity for oxygen, which means it readily holds on to oxygen and it readily gives it off easily. So it doesn't have that ability to sickle like the normal hemoglobin. So switching on that production of hemoglobin F increases the amount of normal red blood cell, or increases the amount of normal red blood cell that is in circulation. And what this does is that it reduces the frequency or the severity of a sickle cell crisis, because you have the fetal hemoglobin in circulation, you have some normal hemoglobin, and then of course you have the S. So what we tend to say is that the ideal level that we want to see the hemoglobin F switched up to is 30%. So if you have 30% of fetal hemoglobin in circulation, you would find that that individual's crisis is reduced, the frequency is reduced, the severity is reduced. And this medication has been around for over 20 years. It's been proven to reduce the frequency of crisis, as I've just said. Chronic blood transfusions, or RSET. So RSET means automated red cell exchange. So blood transfusion therapy is a procedure that is used to treat and prevent certain complications in sickle cell disease. So transfusions decrease the percentage of red blood cells that are sickled in circulation. So so what we do is that it can treat severe anemia and also reduce the risk of stroke and other complications that block blood flow, as I explained. So there are potentially serious risks of blood transfusion, including allergic reactions and iron overload, which is why the decision to start blood transfusion has to be weighed up or balanced up with the benefits and the risks. So the risks and the benefits has to be kind of weighed up. So there are two types of blood transfusion that we can give. Is either the simple top-up transfusion, which the individual comes in every 4 weeks for blood transfusion, or they can have the automated red cell exchange transfusion. So a chronic transfusion, which is the simple top-up transfusion, they have that every 4 weeks. And what that does is that it suppresses the bone marrow. And what that does in turn is that it reduces the sickle cell percentage. So those who are not on blood transfusion, usually their sickle cell percentage can either be between 70, 80s, and I've seen some that are in the 90s. But simple top-up, what it does, it reduces that percentage down to 30%, which I think is fantastic. So what would happen is that they would have reduced, the crisis that they experience will be reduced because majority of the blood in circulation are those donated red blood cells. So donor cells usually last for about 35 days. Which is why when those who are on a blood transfusion program, we tend to reserve, the lab reserves a unit that is less than 10 days because of that short short life of the donated red cells. So a red cell exchange is performed using this machine here. So it's called a automated red cell exchange machine. And what it does is that it separates blood into its various parts. So it removes the patient's sickled red blood cells and then it replaces them with the normal red blood cells donated by blood donors. And the remaining part of the patient's blood, including all the white blood cells and the plasma, are returned to the patient unaltered, and they don't get that complication of iron overload as those with chronic blood transfusions tend to get. So blood transfusion, let's see, so what else? Yeah, so I'm just trying to look at my notes to see if there's anything else I need to say. So as I mentioned, one of the complications of blood transfusion is something called aloe immunization, which is where the red blood cells are, the donated red blood cells are rejected by the recipient. So when this happens at the same time as the sickled cells breaking down, this causes hyperhemolysis. And what that means is that that patient would be severely anemic. And the reasons why this happens is because of patients who are on a long-term blood transfusion program. They may not be receiving the ethnically matched blood. And this is why it's important to match blood types, as this reduces the risk of aloe immunization, which leads to a difficulty in obtaining compatible red blood cell units for patients with sickle cell disease. And of course, that could cause problems in future. And this is why we need more blood donors to please come forward and register to give blood, as ethically matched blood is required in people with sickle cell disease, especially on a long-term top-up transfusion or on a exchange transfusion. And for example, there's certain subtypes that are common in people of African and Caribbean ancestry. So this is the RO subtype. And this is why there's been a huge blood drive to encourage more Black heritage donors to come forward and register. It's very important. So if you can give blood, please come forward and give blood. If you can't, please share with your families, with your friends, with your community, for them to come forward and give blood. Another treatment that has just come out recently is Chrysalisumab. So this is only available for over 16 years old. So Chrysalisumab, what it does is that again, it reduces the severity of a sickle cell crisis by blocking a certain enzyme called P-selectin. And again, that is done by 4 weekly infusions. And it's usually either hydroxycarbamide or chrysalisumab. So I don't know anybody that is on combined therapy because this again reduces the sickle cell crisis, and so does hydroxycarbamide, but they work differently. But like I said, it's only available for children or individuals over 16. Sorry, I'm a pediatric nurse, so I keep saying children, but it's only available for those who are over 16. So some of the curative therapies that you may be aware about is bone marrow transplant. So bone marrow transplant is a procedure where your own bone marrow stem cells are replaced by a donor's. So the healthy stem cells that are produced, so the healthy stem cells that are that has been donated produce normal red blood cells instead of sickled cells. So once it's transfused into that individual, what we are hoping is that the bone marrow would start to make those donated red blood cells. So that would reduce the complications to reduce the symptoms of a sickle cell crisis. But what we tend to say is that although you may have had bone marrow transplant and you've been cured, it's important to still be aware that you carry the same genes. So you can still pass down those sickle genes that you've inherited down to your children. So those who have gone through bone marrow transplants as a child, they need to be aware that when they come to that age where they want to have their children, they need to be aware that they can still pass those genes down to their children. And also gene therapy, which is in the research stages at the moment, but is looking very, very promising. And gene therapy basically involves the fixing of an abnormal gene and adding a new gene. And what the researchers do is that they take blood or bone marrow and modify the stem cells in the lab using some kind of technique, gene therapy technique, and these modified cells are then infused or injected back into the blood, and then that is transfused into that individual. So like I said, it's in the research stages, but it's looking really promising, but we need more funding to be pumped into finding a cure and therapies for those with sickle cell disease. So in conclusion, get tested to find out what your genotype is, because what I strongly advocate for is preconceptual screening. So for you to be aware of what your genotype, what genotype you carry, so you can make an informed choice with your partner when you want to have a baby. If you do want to have children, it's important for you to raise awareness. Talk to people around you, your community, your network, let them know about sickle cell disease and the importance of donating blood. Donate blood if you can. It's very important for the sickle cell community. And sickle cell carriers can also donate blood as well. So please, even if you're a carrier, just go to, I think there's going to be a link. I don't know if Olivia has put it in the chat just yet. Register, and then what they usually do is I think they check your blood work and see if, just to make sure that you're not anemic and you have and you're able to donate, and then they would book an appointment for you to give blood. But of course, those who are carriers would not be able to give to those who are having a long-term transfusion, because usually the units that we reserve for individuals having long-term transfusions would be sickle negative, but you can still help them in other ways. And what else? So yeah, each donation can potentially save up to 3 lives. So that one donation that you give, so for example, I think it's usually 470 or 480 meals that you give, can save 3 people's lives. And the organization that you can find out more information about sickle cell disease is the Sickle Cell Society. And for blood donation. This is the website, and I believe that there's going to be another link put up, but I've popped it here as well if you wanted to register to give blood. Yeah, and that's the end of my talk. I think what I'm going to do is, before we go into question and answers, if we can welcome Bola, who is our volunteer, who's going to be sharing her story with us, and then I'll take question and answers after. Over to you, Bola.
Good evening, everyone. I'm so sorry. I got a bit delayed at work. But thank you so much for giving me the time to talk. My name is Bola, and I volunteer for the Sickle Cell Society since I think 2018, when the South London Give started. Now it's also called Give Love, Spread Love. I developed a passion to help in raising awareness about the blood donation, because I'm a recipient of this good deed that everyone does. I suffer from sickle cell myself with HBSS, and I've been receiving the exchange blood transfusion since around 2018. Actually, it was when I started feeling better that I thought, okay, if this is the only way I can give back. So I joined the society to raise awareness about blood donation and the importance of Black people going out there to donate blood. I have my exchange blood transfusion every 6 to 8 weeks, and that has been brought a great improvement to my life in general. I haven't had any major crisis since I started being on EBT, and yes, I do still get tired, and especially when the exchange is due. However, I haven't had any major episode whereby I'll be admitted into the hospital. And yes, so this is my story. This is the reason why I go out there, just to raise awareness that this thing is benefiting and helping a lot of people to be there for their family, like myself, be there for my children and my husband, and he has improved my life greatly. Thank you very much.
Thank you very much, Bola. Lovely to hear from you as always.
Thank you. Yeah.
Before we end, I just want to remind you all, as we spoke about today, amongst so many other things, how urgent the need for ethnically matched blood is to support people with sickle cell. We do need 40,000 more Black heritage donors. So if you can donate, please register today. I put the link in the chat earlier, but I'll put it in there again now. Before you leave today, we would be really grateful if you could just participate in the closing poll. If you were here at the beginning, you would have entered into the opening poll. So if you wouldn't mind just putting in your feedback now, as I mentioned earlier, it will just be used for internal reporting purposes only. So thank you so much, and I will start the poll now. So you should see that on your screens in a moment, if you don't mind answering the questions before you leave. Thank you so much, and I hope you all have a lovely evening. Thank you, Debbie.
Thanks, everyone. Thanks, Olivia.